Hello, nurses. I'm going to begin some of the hematological disorders involving red blood cells, white blood cells, and platelets. I'm just going to begin this particular PowerPoint that I've done for you just to get us going on these, and we'll probably conclude them tomorrow in class. We're going to start with red blood cell disorders, and as we went through the assessment of the hematological system, we talked about how important red blood cells are. They're probably the most important cells in regards to providing oxygen and nutrients to all the cells and to all the organs. And so when we see our patients have a decrease in red blood cells, causing them to become anemic, hemoglobin hematocrit's low. This is a very serious situation because anemia does affect every system in a particular way. And when we talk about the word anemia, it is a reduction in either the number of red blood cells, the amount of hemoglobin, or hematocrit, which is the percentage of packed red blood cells per deciliter of blood. It's not specifically a disease, but it is a clinical sign and a manifestation that we need to look at very closely and determine what is the cause. Some causes are obviously less serious than others, but the point is it's nothing to be overlooked. These causes of anemia can be from dietary problems, genetic disorders, maybe there's problems with the bone marrow that's producing these cells, or red blood cells are low just because of the fact that someone's bleeding. And it can be a very subtle or a chronic bleed caused from maybe medications or gastritis or some kind of GI problem. So the point is, it's something that we just can't say, oh, the patient has anemia and then go on our merry way. We have to determine what is the cause. And obviously, the more anemic our patient is, the more serious situation it is, and the more we need to intervene as quickly as possible to find the cause and provide the necessary treatment for that patient, okay? Let's look at some of these problems, okay? The first one is anemias from increased destruction of red blood cells, okay? And we call that term hemolysis. And the first disorder that we're going to talk about is glucose 6 PD, okay? And we see this problem with mostly people of African or Mediterranean descent. It is a genetic disorder where there is a defect in the X chromosome and affects more men than women. It's a hereditary defect in red blood cell metabolism, and there is many variations of this genetic defect. If you go back and think about normal anatomy and physiology, G6PD is the enzyme that catalyzes glycolysis, the process by which an RBC derives its cellular energy, okay? And a defect in this G6PD, which is this enzyme, can cause direct oxidation of the hemoglobin, which is thus going to cause damage to the red blood cell. And when we talk about the term hemolysis, okay, it only occurs when a person is exposed to a stressor, okay? And it is one of the most common types of inherited hemolytic anemias that we see. And what could happen is a person can become exposed to a drug, such as aspirin, a sulfonamide, or even a vitamin K derivative, something that puts an increase on metabolic demands of the red blood cell, okay? And with G6PD deficiency, it impairs the necessary compensatory increase in glucose metabolism, because obviously if there's a stress on the cell has to work harder, and obviously it needs more energy to do this. So obviously with that said, it will increase glucose metabolism and thus cause cellular damage. And usually these red blood cells are damaged over a period of about 7 to 12 days, as said on this PowerPoint slide. And when it exposes, when it is exposed to a stressor triggering a G6PD anemia, symptoms will occur within several days. And think about anemia. What kind of things do we see happening to our patients? What do we visually see in our patients? Obviously, over time, our patients can be suffering from pallor of the ears, the nail beds, the palmar creases, conjunctiva, and even around the mouth. Their skin may be cool to touch, they're very intolerant of cold, and their nail beds may become brittle and may lose the normal convex shape over time. Okay, so those are some of the things that we see. Okay, sometimes we see increased tachycardia at basal activity, even increased heart rate with activity and even during meals. Our patients can eventually develop murmurs, gallops, orthostatic hypertension, and headaches and dyspnea. So those are just to name a few of some of the manifestations that we see happen when our patients develop anemia. And as we continue talking about this type of genetic type of anemia called G6PD, if there is a known hereditary cause of it, they will do screening for this deficiency necessary before donating blood, because cells that are deficient in G6PD can be hazardous. We wouldn't want to, give this blood to somebody because of the deficiency of this particular enzyme for red blood cell metabolism. Okay, and you have to think about what is hemolysis. Hemolysis is the breakdown of a red blood cell. So when any time you have that breakdown, as seen in this particular genetic or hereditary defect, you're going to have a lot of cellular debris in the vasculature. Okay, and that's where the seriousness of this occurs. Okay, with all this debris, you need to provide the patient with proper hydration, and to prevent all this debris from kind of collecting in the tubules, causing your patient to go actually into acute renal failure. And sometimes, and we use some of these very potent osmotic diuretics such as mannitol. We used to use this a lot for our neuro patients when they had increasing cranial pressure, causing the patient to diurese and relieve some of the cerebral edema. But because it's so potent, we might want to use it for this reason too, because we want to flush all this cellular debris out of those little tubules in the kidneys, because it's going to interfere with, obviously, renal function. Or we may actually transfuse when the anemia is present and when kidney function is normal, because we want to try to bring up this hemoglobin, okay, because of the hemolysis of red blood cells that are occurring, okay. So that's somewhat of G6PD, which again, remember, when we're talking about some of these anemias, they're due to different etiologies or causes. This one is obviously due to a genetic problem causing hemolysis of those red blood cells, which causes them to be destroyed, causing a lack or decrease in number of red blood cells. Okay. I think that's pretty much the important information that I wanted to provide for you. But just remember, a lot of people that have this, they won't have any symptoms until some kind of stressor or exposure to maybe something that will cause an increased stress on the red blood cell, causing that red blood cell to obviously increase its metabolism. Because remember, again, this enzyme helps the body process carbohydrates and turns it into energy, okay? And this enzyme also protects red blood cells from potentially harmful byproducts that could accumulate when a person takes certain meds or when the body is fighting an infection. So if you don't have it, it's not going to protect that red blood cells as well. Again, it is also said that it can be developed as a protein against malaria. It's a parasite that causes the disease that does not survive well in G6PD. So that's another thing in regards to GP6 deficiency. Okay? So that's one type of problem with red blood cell decreasing. Okay? The next one is immunohemolytic anemia, because now we're talking about these hemolytic anemias, okay, causing those breakdown of red blood cells, okay. And anytime you see the word immunohemolytic, you're talking about a situation where you have immune system components that actually attack a person's own red blood cells, okay? And the red blood cells are viewed as non-self by the immune system, and they attack them and try to destroy them, okay? And with this particular type of anemia, there are two types. There are the warm-blooded or warm antibody anemias and the cold antibody anemias, okay? And if you go back and kind of recall some of your antibodies when you took anatomy and physiology, if you think about the 5 main antibodies, IgA, IgD, IgE, IgG, and IgM, this one, especially with the warm antibody anemia, is usually associated with IgG antibody excess. What we see happen with the warm antibody anemia is that it usually happens with patients that are 50 years or older, okay, that actually the immunoglobulin, IgG, actually attacks the red blood cells when that react at temperatures of 37 degrees or greater, okay? So that's what we mean by the different warm as versus cold, okay? The warm antibody anemia is most common with women. And obviously it depends on the severity of the anemia, and the warm is obviously the most common type of the two. And it will obviously depend on the symptoms that occur, okay? And many times we've seen the treatments with steroids, splenectomy, medications, and plasma exchange therapy. Excuse me. Plasma exchange therapy is when they actually, it looks like a dialysis machine, and they put those patients on there and they actually exchange their plasma for new plasma, because remember, it has those antibodies or immunoglobulins that see the body's own red blood cells as a foreign substance and attack it, and then of course destroy it, okay? The cold antibody anemia is associated with fixation of complement protein on IgM and occurs best at 80 degrees Fahrenheit or 30 degrees Celsius. And this problem is usually associated with a Raynaud's-like response in which the arteries in the distal extremities constrict profoundly in response to cold temperatures or stress. Okay, So that is what happens with the cold immunohemolytic anemia. Again, steroid therapy for mild or moderate, and like I said, if it's a very severe manifestation of the anemia, that's when they'll do a splenectomy or a more intense immunosuppressive therapy with some of the medications like cyclophosphamide and azathiopurine or Imuran, used if the steroid therapy does not prove to be successful. So that's that particular type of hemolytic anemia. All right, now we're going to talk about anemias from decreased production. The last two, the GP the glucose 6-PD and the immunohemolytic anemia were obviously decreased red blood cells, but they were caused by hemolysis. Now this is just a decreased production of red blood cells due to a problem with making the red blood cells, okay? And these ones are a little bit more common and will probably be a little bit more popular with some of our patients that we care for. Okay, iron deficiency anemia, or also called microcytic. If you go back to what I said earlier in the assessment lecture, which some of you may be listening to right now, it looked at the size of the cell. Well, with iron deficiency anemia, you're going to see on the CBC that the patient's size of the red blood cells are much smaller than a normal healthy red blood cell, and we call that microcytic, okay? This is probably the most prevalent worldwide type of anemia that we see. If a person has iron deficiency anemia, iron stores are depleted first, followed by hemoglobin stores. So before you would see the hemoglobin start dropping, the body would use up all the stores that it has. And once those are all depleted, then you're going to see the hemoglobin and stores start to decrease. And as a result, red blood cells are small, microcytic, and the patient will have mild manifestations of anemia, okay? They'll have weakness, some pallor, okay? If they're suspecting that the patient does have iron deficiency, they will also do serum ferritin levels, and they'll be less than 12 grams per liter. They'll do transferrin, as I said, and probably total iron binding capacity levels on the patient, okay? Most of the time, iron deficiency will be due to poor nutrition. Remember, the body contains about 2 to 6 grams per deciliter of iron, and 2/3 of that is contained in hemoglobin, and the other third is obviously in your bone marrow, okay? And your spleen and your liver and your muscles. This is a very common type of anemia in patients who are very young and who are very old. Even kids that are finicky and who don't eat much meat, and also the elderly who don't eat much meat due to the fact too large of portions to cook often. And we see this more obviously in women than in men. Manifestations: mild anemia, weakness, pallor. Red blood cells, as I said, are microcytic, which are small in size. Hemoglobin and hematocrit may be, mildly decreased. Serum ferritin levels will be less than 12 grams per liter, and you're going to have decreased iron stores. So we can fix this fairly quickly within a few months by just doing some nutritional counseling with these patients. Food sources of iron that include red meats, liver, organ meats, green leafy veggies, carrots, raisins, dried fruits, and egg whites. Those are probably the best source of usable iron. Kidney beans, whole wheat breads and cereals, and fortified juices and formulas. You need about an adequate day supply of 10 to 15 milligrams of iron a day, but remember, only about 5 to 10 milligrams of that is absorbed. So with diet alone, it may take up to 6 months to fix, to replenish those iron stores, okay? And if a person doesn't follow a diet or eat the foods that we suggest, maybe by ourselves as the nurse or by a dietitian, meds may be given. We might see the patient ordered to take ferrous sulfate, 50 to 100 milligrams, maybe BID. That drug is better absorbed on an empty stomach, but unfortunately on an empty stomach it can really cause a lot of GI distress. But don't give with meds that would coat the mucosa lining, such as, Mylanta, antacids, things like that. Remember to warn a person who is on a ferrous sulfate prescription that they will have black tarry stools and may even be constipated. It's best if someone could drink this with a drink containing vitamin C, because it provides better and increased absorption of the drug, preferably orange juice. Give before meals to facilitate best absorption, but can be given with meals if poorly tolerated. But it's definitely going to cut the absorption by about 30 to 50%. So they need to know that. So they might have to be taking it a little bit longer. Patient will start to feel better in a few days, because what's going to happen is you're going to have increased reticulites in 7 days. But remember, it'll take about 6 months after the hemoglobin hematocrit return to normally replenish those stores. Okay. There might be some iron Z-Track, but I'm not sure how often we're using that anymore. I know they're doing a lot of the IV infusions, like with Venafir, in the outpatient clinics. That's also another possible choice of treatments for this problem. But really, it's not real serious. We can fix it, and like I said, the hemoglobins may be somewhat, decreased, but not severely. But your patient still may feel somewhat fatigued and have a little bit of pallor going on, but the symptoms are pretty much mild when we're talking about iron deficiency. But remember, the size of those cells will be very small because they don't have enough iron to make them look like a healthy red blood cell. So that's why we label them microcytic. Okay? All right, the next one we're going to talk about, and this is another one that is fairly common, vitamin B12 deficiency. This can actually have mild to severe symptoms. It can develop slowly. Initially, it produces few symptoms. Pallor is one. Sometimes even jaundice, glossitis, which is that beefy red tongue, fatigue, and even weight loss. All right, you've got to go back to what the role of vitamin B12 is. It actually helps to transport folic acid into the cell for DNA synthesis by acting as the cofactor responsible for activating the enzyme responsible for transport. So if you have a person who has a vitamin B12 deficiency, it indirectly causes anemia by inhibiting folic acid transportation and limiting DNA synthesis in those red blood cell precursor cells. So what happens is the precursor cells improperly increase in size, and only a few are released from the bone marrow. So what you get with this type of anemia is a megaloblastic anemia, or a macrocytic. It's anemia of a large size of abnormal cells. So it hasn't really fully matured, but it's large in size, and that's why we call it macrocytic. Okay. Vitamin B12 deficiency can be caused by a few things. Okay. It can be caused by dietary deficiency, where you don't eat foods that have a good source of vitamin B12. It could be the fact that you don't have part of your small bowel because you don't have your the intrinsic factor, diverticula, tapeworm, or overgrowth of intestinal bacteria that can lead to poor absorption of vitamin B12 from the intestinal tract. We call that failure absorb B12 called pernicious anemia. And when we talk about these megablastic or macrocytic anemias, as I said before, the red blood cell fails to mature, and that reticulocyte fails to mature. And as I said, there's two kinds, and the one kind I've just mentioned is your vitamin B12 deficiency, and we call that pernicious anemia. And that can result from a deficiency of intrinsic factor. And again, pernicious anemia may be mild, but it can also be severe, okay? And think about what else vitamin B12 does. It is necessary for nervous system, and it really provides good nerve health. So very often the person may have problems with abnormal sensations, which we call paresthesia, in the hands and the feet, and even disturbances of balance and gait, okay? And the key features of vitamin B12 deficiency are severe pallor, slight jaundice, smooth, beefy red tongue, fatigue, weight loss, difficulty with gait, and paresthesia of hands and feet. So the important thing to do with these patients is to obviously provide foods in vitamin B12, liver, organ meats, dried beans, nuts, green leafy vegetables, citrus fruits, and brew as yeast, okay? So this is one type of macrocytic anemia called vitamin B12 or pernicious anemia, as anemia resulting from that failure to absorb B12, okay? And again, caused by deficiency of the intrinsic factor. And what they'll do is they'll do a test for pernicious anemia by the Schilling's test. And if that proves to be positive, then just the treatment is they'll give vitamin B12 weekly at first, then monthly for the rest of their life, because they're not going to be able to absorb it. This Calamus was used in the past. I'm not sure if they're using it anymore, because I think there was some question whether or not it was being absorbed very well. And remember too that you can kind of differentiate between these two macrocytic anemias, B12 versus folic acid, is by that paresthesia, or that peripheral neuropathy that your patients may experience or complain of. And they will have definitely a decreased production of the myelin sheath, causing the patient to complain of numbness and decreased sensation. And some of these people will get some relief from that pain by giving them a medication such as Neurontin, and then of course giving them cyanocobalamin, which is another fancy word for vitamin B12 injections, but they're going to have to take it for the rest of their life, okay? And I personally am getting those once a month, and it really helped me quite a bit in my anemia, and also from that that type of tingling and numbing sensation that you get in your feet and in your hands, okay? And as I said before, the Schilling's test, just to say a little bit about this, is it's used to validate pernicious anemia or vitamin B12 deficiency. It really measures the body's ability to absorb vitamin B12. What they do is the patient is NPO for 8 to 12 hours, and then they're given an oral radioactive tag dose of vitamin B12, followed by an IM dose of vitamin B12, after which a 24-hour is done. If that tag shows up in the urine, then they have the intrinsic factor necessary to absorb B12. And that's an enzyme that's released by gastric mucosa change that in which the vitamin B12 is taken in. If the tag shows up in the stool, then they are lacking the intrinsic factor necessary to absorb vitamin B12, and then they're said to be diagnosed as having pernicious anemia. Obviously, alcoholics will often have this due to a lack of good nutrition. Often happens between the ages of 40 and 60. Women more than men, maybe from a scarring of gastric surgery or hereditary issues. And again, how we treat this is vitamin B12 IM injections. But the important thing to know is, which I thought was very interesting, is you would have the loss of intrinsic factor and the ability to absorb B12 for 5 years before you're actually symptomatic with the problem. So that's quite interesting that your body has that much leverage to keep going until you actually start to show symptoms. And another thing is, think about, as I said before, some of the lab values that we would draw, especially when your patient is iron deficient. You're going to obviously see low iron levels. Your TIBC will be high and your ferritin levels will be low, and that is obviously showing us iron stores are not there. And many times that's what they'll do again when they put a person on, like, say, ferrous sulfate or even a vitamin B12, more for iron deficiency. They'll look at those ferritin levels because that really denotes iron stores, and we know we need iron to make red blood cells. So if we see those still depleted, then the patients will continue with their treatments, whether or not it's ferrous sulfate or maybe a weekly or a monthly Venofer or iron infusion. Okay, so that's that. So the next one, again, one of the macrocytic anemias is folic acid deficiency. Okay, and this is manifestations are very similar to those that have vitamin B12 deficiency, but the nervous system functions remain normal. Okay. We see this more common in alcoholic populations. Common causes include poor nutrition, even some of your malabsorption problems in the GI tract, such as like Crohn's disease, and even some anticonvulsants and oral contraceptives can cause folic acid deficiencies. Okay, but again, it's one of those megaloblastic anemias, but you have the absence of neural problems that differentiates folic acid anemia from vitamin B12 deficiency. But like I said, some of these medications may actually cause this because it interferes with the absorption of folic acid. Usually oral folic acid 1 milligrams daily, or I am for patients with absorption problems, and also nutritional counseling and education about what foods are good for folic acid sources. Green leafy vegetables, liver, yeast, citrus fruits, dried beans, and nuts. Like I said, the manifestations are very, very similar to vitamin B12 deficiency. Okay? All right, the next one we're going to talk about is aplastic anemia. Okay, now we're getting into some very serious situations occurring with our patients. Okay, and let me move this along. All right. Aplastic anemia. Okay. This is basically bone marrow failure. Okay, it's a deficiency of circulating red blood cells because of failure of the bone marrow to produce these cells. Okay, this is the term that we refer to as pancytopenia, where there's a deficiency of all 3 cell types caused by a injury to the hematopoietic precursor cells or the pluripotent cells. Remember the stem cells we talked about, which is how every one of our cells start out as. Patient may present with a hypoplasmic bone marrow. Say, for instance, they were having a bone marrow biopsy done. You may actually get a dry tap and be unable to remove any type of marrow because the bone marrow now is failing. Okay. We see this many times with patients who have leukopenia, which is a reduction in white blood cells, and thrombocytopenia, which is a reduction in platelets. Now, can you imagine a person who now is deficient in all 3 cells, which puts them at risk for severe anemia, increased risk for infection, and obviously increased risk for bleeding. Okay? And of course, think about what kind of symptoms you would see. Weakness, pallor, petechiae, ecchymosis, CBC, you'd see severe macrocytic anemia, leukopenia, and thrombocytopenia. There are 3 types of this aplastic anemia. Acquired, which would be transmitted from parent to child, and then congenital, which is present from birth, and Fanconi's anemia, which can be caused by defects of DNA repair. Now, it is a rare inherited bone disease that leads to bone marrow failure. That's what Fanconi's is. But aplastic anemia is just basically bone marrow failure. Okay? Sometimes a person may have had exposure to radiation, or maybe they've had a viral infection, and this would just cause their bone marrow to unfortunately quit working. It becomes just a very incapable bone marrow to produce any of these cells. Sometimes it can be from exposure to malarial toxins. Back in the 80s, chloromycetin was a very popular antibiotic, and when a person, was prescribed that, one dose could do some very serious damage. Some of the anticonvulsives like Tegretol and Dilantin can cause myelotoxicity. Even some of the chemicals used to remove like mold in someone's home, carbon tetrachloride. The treatment for these is to destroy, help to reduce the destruction of cells, so they would do a splenectomy on these patients. Glucocorticoids stimulate bone marrow and reduce destruction of cells. They might give transfusions, obviously, to help supplement the red blood cells. Maybe give androgens, which is usually testosterone, to simulate erythropoiesis. Even short-term, give Epigen or Neutrogen. And Epigen is a synthetic growth factor to help in the production of red blood cells, and Neutrogen is to help in the production of white blood cells. What they'll do is put a patient in a myelosuppressed state and then do a bone marrow transplant. And bone marrow transplant is probably the best treatment for remission. Okay? And that is what we can do to treat aplastic anemia. Okay? We'll get into more detail about bone marrow transplant. I want to kind of go over that process after we talk about some of the red blood cell problems. I'll probably just do red blood cell problems, and then tomorrow in class I'll start with leukemia. Okay? Okay, the next one we're going to talk about is polycythemia vera. And this is an erythrocytosis, which is an increased red blood cells in the whole blood. But this is a very serious type of polycythemia, where it's more of a neoplastic disorder, which is a cancer of the red blood cells. And if it is not treated, it is a fatal disease. The 3 hallmark manifestations is the massive continual production of red blood cells. So you have increased red blood cell concentration causing sluggishness in the blood, excessive leukocyte production, which are basically immature white blood cells that are doing a bit of good for the patient, and an overproduction of thrombocytes, which produce dysfunctional platelets, which aren't doing the patient good otherwise. What you're going to see with this is the patient's manifestations or presentation will see a person with very plethoric appearance, and that's because you have all these red blood cells on board, which give that patient that very flushed red coloring, like as if a patient's in a continual blushing. They might also have other signs and symptoms where they have intense itching, blood viscosity increases resulting in hypertension. What else? High risk for clot formation, cell lifespans are shorter, there's sludging of the blood causing gout and hyperkalemia. Because what's going on here is these cells are breaking down because they're very immature, so they're very fragile. So you have a lot of the inner contents of these cells, the intracellular contents, are kind of going out into the vasculature because of the fact that they're breaking down, and you're having hemolysis of these cells. So within the cell are like potassium and uric acid, and these substances are then being released out into the vasculature and out into the circulatory system. So that's why your patients develop things like hyperkalemia and uric acid overproduction, causing them to develop gout. Now they also can have headaches, dizziness, which increases the risk for bleeding, tinnitus, which is, obviously increased blood viscosity. And then they're going to have very, very high hemoglobins and hematocrits. Some of these hemoglobins are well over 20, and the hematocrits are well over 60%. And as I said before, we're very concerned about hyperkalemia for the fact that the patient may start having cardiac arrhythmias. Okay, so obviously our goal is to get these cell counts down and hopefully have the bone marrow produce normal, healthy cells. And so we have to do a phlebotomy. And a phlebotomy is take a certain portion of blood volume out of the person. Usually they take out about 500 milliliters at a time to get that hemoglobin hematocrit done. We properly hydrate because remember how we talked about sludging. And then, of course, anticoagulants to prevent the problem of clot formation. Okay, so that is... polycythemia vera. Now this is different from polycythemia, where we would see that happen in our patients who have heart failure, where they have that state of hypoxia that kind of triggers erythropoiesis to happen. But this is a little bit different, or a lot different I should say, where the patient now has a type of polycythemia, but this is more of a neoplastic or cancer of the red blood cells. Okay. So they may also give the patient anti-neoplastic drugs, and that's a fancy term for pretty much cancer drugs. They may do, of course now we have to definitely watch our patient for infection and bleeding because we've got very unhealthy white blood cells on board. We've got a lot of them, but they're not mature and they're not really doing anything to protect the patient against harmful organisms and pathogens. And of course, with the overproduction of thrombocytes, the patient's at extreme risk for bleeding. Okay, so those are our concerns when our patients have this until we can get some treatment on board and hopefully, get this worked out so that we can get some normal cells on board. Like I said, if it's left untreated, a patient will never live longer than 2 years. The phlebotomy they'll do 2 to 5 times a week prolongs their life about 5 to 10 years. Okay, so and the thing too is you think about the massive amount of red blood cells, and what can happen cardiac wise is it puts obviously added stress on the heart muscle. So many of these patients can develop chest pain because you think about how thick this blood is and how hard the heart has to work to pump this. So the patient may develop chest pain and CHF and also develop possible strokes and bleeding. So, that's our big concern. Because with this increased amount of red blood cells, there's a lot of vascular stasis where the blood becomes very slow flowing. And it's a very serious situation. I'm not sure if there's really any kind of cure that we can do with this except just treat the symptoms and just watch how the patient responds to that. But remember, the blood in itself is very hyperviscous, okay? So that is polycythemia vera, okay? And then the next one that we want to talk about here is myelodysplastic syndrome. And this is a syndrome in which, if you go back to, again, remembering stem cells, this particular syndrome is stem cell disorders in which stem cells fail to reproduce and differentiate into various types of blood cells. Bone marrow loses its ability to produce normal blood cells, so they produce abnormal blood cells. Usually the first sign of this is patients become anemic, okay? And it usually can occur at any age, but really we see it more in over 60, maybe even 55. And the seriousness of this is obviously the anemia, but it can be considered to be a precancerous state, okay? Now, they may start off as anemic, where their red blood cells are low, but they can also have decreased white blood cells and platelets, okay? And later on, we might see more serious issues like splenomegaly, hematomegaly, thrombocytopenia, and obviously neutropenia. 30% of all the patients who develop this will develop leukemia. The exact cause is unclear. There's a lot of risk factors, as you can see on this PowerPoint slide: aging, chemical exposure, tobacco smoke, chemo, and radiation. Diagnosis is genetic examination, and how we treat this is blood and platelet transfusions, erythropoietin for the hopefully increase of red blood cells, chelation therapy, because if you're giving your patient a lot of blood transfusions, we worry about the possibility of excess iron in the system, because each unit of red blood cells have about 250 to 300 milligrams of iron. And if you have a lot of increased iron in the body, it can't excrete it fast enough. So you might have to use iron chelation therapy, which helps to remove that excess iron. So that's why it's really important to know signs and symptoms of iron overload, and also to definitely monitor and evaluate iron stores, okay, and iron levels in the body. Desferal is given slow IV infusions, or they can also do continuous sub-Q infusions. They may give, platelet infusions, antibiotics, but chemo is very ineffective in treating myelodysplastic syndrome. Stem cell transplant gives the most help, and one celebrity that had this was that Robin Roberts from Good Morning America. She had this a few years ago, and her sister was a match, and she had a bone marrow transplant, and she did very well from it, and she's completely cured, and really has talked about the importance of getting on the stem cell registry to be a donor for somebody who is in need. And so she sent a very powerful message, and that is a very good point to bring up. So that is pretty much all the red blood cell problems that we're going to talk about. That's all I'm going to do in this video. We're going to start with anemia tomorrow, not anemia, but leukemia tomorrow, and then we'll finish up with the platelet problems. And then we'll conclude with some of the nursing care and interventions that we do for our patients who have had chemo, and some of the unfortunate side effects that we see with chemo, and what we can do to help our patients. So this will get us a little farther ahead, that we should possibly finish tomorrow, and then we can have our test on Thursday, and then you don't have to worry about a test over spring break. So thank you for your time, and if you have any questions, feel free to ask me in class tomorrow. And you all have a very, very nice evening. Thank you.